All right, thanks, Jonathan. Thanks everybody for hanging in there. And Rand, this topic might be less popular than yours at the Mayo Clinic, but I would just argue for us to hold tight for a minute, hear me out, and just acknowledge one fact that probably 10 years ago, if we'd have brought outpatient primary hip and knee replacement to a meeting, everybody would have said, nah, come on, that's a stretch. And look where we are today. Almost everybody, including the Mayo Clinic, is doing same-day outpatient discharge. So hang with me. I'm going to present some very early data and my thoughts around all you've learned, these past 3 days have been incredibly, hopefully beneficial in terms of techniques, diagnosis, all around the revision space. And can we do this and get patients home sooner? So we'll just walk through that. My disclosures are relevant. So not only do I work on a risk stratification tool for outpatient arthroplasty, I also have ownership shares in ambulatory surgery centers and a company that owns multiple. So I do get a benefit for promoting this particular topic, but we want to maintain safety. So my disclosures are relevant. So outpatient joint replacement, I don't think any of us in the room would ever argue that there are multiple factors that are fueling this across country. Surgeon investment in ASCs is one of them. It's not the only one. It's probably not the most powerful one. The ability to control your own environment in an ASC is very different from the bureaucracy of a big hospital. And now, post-COVID, the resource constraint that occurs in the hospital has caused us to look at ASCs in a different way, as a place to get more operating rooms and ability to take care of the huge amount of hip and knee replacement patients. Then we're looking at cost control from the payers and the government that cannot be overlooked. And now we're getting more patient demand. Why is there more patient demand suddenly? Because people associate hospitals with sickness. And so now we're getting more patients saying, oh, I don't have to go to the hospital. That's great. We didn't get that before. So the times are changing. There are a few decisions that have led us to start talking about this, particularly in the revision setting. So all of you will probably know and recall that CMS removed primary total knee arthroplasty from the inpatient only list in January of 2018. That was followed by all these events, right? So then primary hip came off, then total knee got an ASC code, then primary hip got an ASC code. And then we had CMS removing revision knee and revision hip temporarily from the IPO list, then it went back on. So good thing our government's got it all figured out. Good thing they're consistent, stable, and reliable, but who knows where this is gonna go, but I'll bet you it comes back off at some point. So let's look at our data. This is same-day discharge in primaries, and the reason I put this forward is so I would anticipate some form of revisions will follow this. Those gray bars are 2018, 2019. The red bar is 2020. You can see where the COVID shutdown was and what the bar did. So the y-axis is the percentage of our primary hip and knee replacement patients that were done same-day discharge. Now, if you look at 2021 overlying that, and 2022 is no different, it is a substantial amount of patients, and we're a tertiary medical center in the state of Indiana. So right now, as it stands, we sit at all of our primary joints, that includes patients on dialysis, autoimmune disease, the whole 9 yards, we sit at about 70 to 75% of our patients go home the same day, and about 50, I looked at it 2022, 56% of my patients are done in an ambulatory surgery center of primaries. So that brings the question, what about revisions? Now all revisions are not the same. We're not talking about train wrecks, cup cages, some of the stuff we were playing around with in the lab. That's not appropriate for ASCs. Maybe when I'm retired it will be, but for now that's not the patient we're talking about. But in select patients, in select settings and cases, and with select surgeons, and that's the part that's a little bit tricky, but I don't believe all surgeons should be doing revisions in an ambulatory surgery center, but there might be some of you in this room who feel comfortable doing that. The key is we all know these essential elements now, and we're all comfortable with them because we do them in our primaries, right? The staff get used to it. Everybody starts becoming familiar with the protocols and pathways, and then everybody, including the patient, is comfortable. In fact, Mayo Clinic has taken a lead in perioperative pain control in the country on how to make these patients recover more quickly. So now, you look at patient selection, which patient should it be? We've done work on that, but I will tell you, these are the big ones. A motivated patient, they have good family home support, they're a good physical and mental condition, minimal pre-op narcotics, moderate surgical complexity, we'll talk about that, and then how are they medically? The bottom line is we've done some work on this. I'm not going to go into it in detail. The bottom line is look at them medically. Make sure they don't have major comorbidities. Make sure they're controlled. We've shown this as a reasonable and reliable way to approach patients medically. And when we use those protocols, we use that methodology and we screen for these. These are the 5 things I screen for in my clinic. History of urinary retention, uncontrolled sleep apnea, and that's uncontrolled, controlled's fine. Chronic opioids, any history of post-op nausea or ileus or poor home support. If we do those, then the past 8 years, using those protocols in primaries, we've only had 1 failure to launch in our ASC. That happened to be my brother-in-law's mother, but I'm being recorded right now, so I'm not going to comment further. We'll just say that that was the only one we had failed to launch. So let's look at our early data. So this is not surprising. The first bit of information we could find published on this came from Adolph Lombardi and Keith Barron. But what you'll notice here, and I want to point this out, this is really important. These aren't huge revisions. So over a 5-year period, they did 106 revision total knees. 43% of those were uni conversions to a total, okay? And I'm sure they weren't train wreck unis like Raphael's just talked about. These were probably basic. And then 38% were just isolated polyethylene exchange. You could argue that shouldn't be done very often anyway, but that's beside the point. And then only 7 of those entire series were full component revisions, okay? So we're starting out slow, appropriate. We're starting out slow in this aspect of same-day discharge. But 88% were discharged the same day, 13% or 13 stayed overnight, 4 were for convenience reasons, and 9 were for medical reasons. So we just published this in Journal of Arthroplasty, and these are not next day. Most of these are, sorry, these are not same day. Most of these are next day discharge. What we did was we matched 183 early discharge revisions, these were real revisions, to 183 later discharge, and just made sure we weren't doing anything wrong. Now there's some selection bias in here, right? So if they're going home earlier, they're not really sick, so we tried to match them to those that would stay longer, and we didn't find any difference. Here's the data. What's interesting is in the hips, it was mostly ALTR. Those were probably, most of them were headliner exchanges, taking a cobalt chrome femoral head and putting a ceramic in. And then most of the knees were for flexion and stability, which represents a bias that we have in our practice because we do a lot of those. So the subsequent to this is what Christine, our fellow who's here, just looked up and reported. These are true same-day discharge revisions. There's not a lot. Most of them are post-COVID, but there were 35. If you look at the data set, 55% of the hips were conversions. I'll show you some examples. And instability. And then total knees, instability, and conversion from unis to totals were the most common. So not dissimilar to what Adolph and Keith showed. We were successful in 34 of the 35 going home same day. We had 1 patient stayed over for persistent hypoxia. So here's just 2 case examples of people we have recently done same day discharge. 67-year-old female, painful left total knee, moderate and well-controlled comorbidities. This is a flexion instability case. We did that same day discharge. You can see all the principles that Jeremy talked about earlier. Here's another case example. This is a 63-year-old, very active male. You can see had a stent in 2008, was in great shape, very active. In fact, sought this particular device out. He met that result that we all expected would. 2 years, he's notching his anterior femoral neck so that his activity was compromised. And then we did this, and that's a same day discharge, and he did very well. So in summary, I think we all know it's accelerating. Patient selection is critical. I think you need to look at yourself, understand your OR times. We looked at our OR times very closely, minimize your blood loss, and it probably can be done pretty safely. And because this is the last talk, I'm gonna eat up a couple minutes. I wanna say thank you to everybody who's here. This is a special place. That's my mentor, one of my mentors, Mike Cabanella, one of my other mentors, my fellowship director. At the time, Dave Llewellyn's sitting in the room. This is, you'll know that's a younger Brian Springer and Michael Meneghini pulling on Arlen Hanson's tie. We mentioned him multiple times in the last 3 days, and he's now retired. And it's on to future friendships. This is Matt, Abdel, and myself, and all of our families. We spent some time together. This is, of course, James Brown and Matt and I. This is a great family, I think, that is continuing to evolve. And then finally, this is fresh off the press this morning. This is Fedorchek's, Abdel's, and Meneghini's kids. Not all of Meneghini's kids are in here, even though there's more of them. Some are at home, some are in college. It's all over the place. This is just a potpourri of Fedorchek, Abdel, and Meneghini kids. So thanks everybody for a great course, and appreciate your time. And Jonathan, take over.